All right. Let me just accept the recording. Hi, everyone. My name is Heidi Hagen McPherson, and we have Dr. Sharma joining us. Quick overview of what we want to cover in the next hour. We're going to talk about the work of the CARE Network and the closed loop referral. We've got a quick demonstration video that we're going to share with you. Then we're going to share some of the accomplishments and lessons learned to date, and then look at what's coming next. We're looking also to reserve some time for question and answers before we close. And then Srila, do you want to do a quick introduction?
Yeah, hi everyone, Srila Sharma. I am a faculty at the School of Public Health, University of Texas School of Public Health, and also a director of one of our research centers here, Center for Healthy Communities, and co-lead the Coalition for Connected Care alongside Heidi, and look forward to sharing the work that we've been doing over the past few years. So maybe we can jump to the next slide. So we want to start out by acknowledging many of our partners that have been with us for the past few years as we've developed the CARE Network. Really, we did a CARE Network demonstration project, which was really to pull together the framework and implement it and assess and evaluate it. And so we have some of that journey that we're going to share with you today. But just want to call out our partners and collaborators here on this screen, without whom this demonstration project would not be successful. We also want to thank our community advisory group of moms who've been actually working with us for the past couple of years, since March 2024, and have provided input on various things, including the procedures related to the CARE Network. We wanted to ensure that lived experience is really driving the strategic direction for this work. And to quote one of the moms, they essentially told us that all we want is a seamless service experience. If we can get it from Pizza Hut, why can't we get it here? And what they were meaning by that is that when they're using the Pizza Hut app or the portal to order their pizza, essentially they know what type of a pizza they're getting. They know when it's going to arrive at their door, and they can change their order or cancel it or add things as they go along. And that was kind of the seamless service experience that they were hoping to get in terms of care coordination, because they're already seeing it in other spaces and experiencing it there. And why not here as well? Next slide. So just as a reminder, this project is part of the work that is being conducted through the Coalition for Connected Care, previously known as the Health Equity Collective. We have a lot of information on the website that you can see here, and also join us on LinkedIn if you're not there already. Next slide. So we want to frame the conversation today starting with a little bit of the bigger picture. So this work, as I mentioned, is part of the coalition's efforts with the intention of driving better health together. And the coalition really is a systems coalition that's aiming to improve care coordination for non-medical drivers of health in the greater Houston region. And a systems coalition have best worked when they use a collective impact effort. And as many of you may already know, collective impact happens in our work groups, and they're focused on many of the living conditions that you see right there in the middle below. And we have a common agenda. Every work group develops a shared agenda and then works on those agenda items through the year. And every year, those agenda items are revisited and tweaked and edited as we move further together. Our role at UT Health Houston is really to serve as the backbone organization. And that means two main things. We serve as the administrative fiscal home for the coalition. And then we also provide support for all the coalition activities, including the work that we're going to share today. The coalition was formed in late fall of 2018. So we've been around for a few years. Originally, there were three backbone organizations. So one to acknowledge the support of American Heart Association and Harris County Public Health, who are also the backbone leads. And since then has grown to over 1,600 members at this point, representing over 385 organizations who are actively working in these spaces. Next slide. So that framing was really important because that's where the vision of the CARE network came from. So CARE network stands for Community Assistance and Referral Exchange Network. And that was really developed as part of the data sharing ecosystem work group. Since then has sunsetted, but the intent of that specific work group was to look at what the landscape was at the time in regards to care coordination, and how do we connect the dots to have that seamless service experience that our patients are asking for. So to further frame, we wanted to share the next slide. So that this work of actually visioning the data sharing, visioning the care network came from this landscape scan that you see in front. So if you're getting dizzy, you're right on cue there, because there's a lot here. But what you have on the left are health systems, a snapshot of health systems. And what you have on the right in the purple boxes are the community organizations that are engaged actively in care coordination. And then what you see here in the smaller sort of blue bubbles on the left-hand side are the different technologies that the health systems were engaged in. Now, this landscape scan was conducted back in February 2020. And then on the right-hand side at the very top in the teardrops, you see the different care coordination platforms that many of these health systems were using to connect their patients to the community organizations for health-related social needs. Now, 6 years ago, I think it's important to level set that it was a time where health systems were really getting into this space and gearing up and ramping up the screening related to health-related social needs. So many of them had started doing system-wide screening or were institutionalizing screening within their systems. And then, of course, if you're screening, then doing something about it. And so that's where a lot of this engagement with different types of care coordination platforms came underway, so that there could be a seamless referral experience. Now, the challenge when we spoke to all of these stakeholders and obtained information on what is happening in regards to care coordination was that less than 50% of the referrals were actually getting successfully filled. So the service delivery was less than 50%. And when you really looked at the data on mental health related services and those further vulnerable populations, it got to even as low as 10%, which means that 1 out of 10 people and up to 5 out of 10 people were actually receiving the services they were referred to, despite being in an ecosystem where a lot of care coordination technology was available. The second challenge was from the lens of the community organization. So if you think, I'll use an example of our fantastic partners, Houston Food Bank. From the food bank lens, they are the ones who are actually providing the service, right? So whether it's food or other types of services that they link their patient to, they're the ones who are actually doing the service delivery. And so whatever we build, it has to work for them. And what we learned was that the Houston Food Bank, for example, was having to connect with multiple disparate technologies that were not talking to each other. And not to mention the level of investment that a community organization would have to do to engage in these care coordination platforms. So that in the long term, as these initiatives were scaling, just seemed untenable. And so what we heard that, well, wouldn't it be great if we can leverage? So if you go to the next slide, Heidi, yeah, you can click. So what we heard was that, well, wouldn't it be great if we can leverage? We've invested in a lot of technologies. Can we connect these technologies in a way that makes sense for our patients and our communities and the community organization that is actually providing the service? Because the challenge really is that each social service organization is having to make a one-off connection with each healthcare organization. And we're in the largest medical center in the world. So this is not a trivial task. And Houston Food Bank is one of the most sophisticated nonprofits. What about the smaller nonprofits? That is certainly out of their realm of possibility. The other challenge from healthcare organizations is that they don't have sightlines on patient screening and referral from other organizations. So there's a lot of efficiency of care, right? I mean, you could have a patient from UT Physicians who is also screened at Memorial Hermann and both being referred to the food bank. So you have two referrals for one patient that could potentially be happening without any understanding of whether that referral has actually gone through, and for the food bank to know when and how these referrals are coming in. So from the people who are actually delivering the service, so imagine if Pizza Hut was receiving two referral, they had to make two deliveries to the same house for the same pizza. It would not be very efficient from the Pizza Hut standpoint. So it wasn't just about effectiveness, it was also a challenge related to efficiency. So given that, that was the challenge that was put forth in front of the coalition. And so we said, okay, well, let's see what we can do about it. So our bold goal was to achieve seamless, efficient, interoperable, closed loop coordination across healthcare and social service organizations spanning existing networks so that every patient with an identified social need receives the right service from the right provider at the right time. And the right time is really important because if I order a pizza today and it arrives cold tomorrow, that's of no use to me. I was hungry yesterday. And so when we think about the timing, that is an important component of this type of care coordination work, because we are really talking about basic needs. These are critical to maintaining health and just life and well-being. So this was our bold goal that we set forth on trying to achieve. Next slide. So we built, as part of this work, so we've been on this journey since that landscape scan in 2001. So it's been a few years. And for us, it always had to start with governance. Governance has to drive technology. And what does governance mean? Governance doesn't mean control. It really means shared decision-making processes. If we have multiple organizations around the table who are connected to the same patient, the same client, the same neighbors, the same individual, then the decision-making has to be shared to best meet the client's need. So there had to be, we've established a collaborative governance process, and we wanted a governance process that was sustainable. So it couldn't be very bulky. And thanks to our partnership with Daro, David Goodman and Richard Bartle-Tubbs really helped us think through these very complex challenges around collaborative governance. And we are at a place where we now have the governance models and the documents that are needed in place to onboard organizations simply and seamlessly. And another part of the governance was also data sharing. There was data sharing, right, between HIPAA and non-HIPAA covered entities to facilitate the referral. So that was another piece that was driven as part of the collaborative governance process. The second piece, really building technology capacity for this referral work to happen, because what we are hoping, remember, that is to create efficiency and sightlines. So we've really leveraged our health information technology, Health Connect Texas, their master patient index, to build this closed loop referral out. And what an MPI means is that if I went from UT Physicians to Memorial Hermann, and my physician at Memorial Hermann wants to see a certain record of mine that sits at UT Physicians, they can leverage the Health Information Exchange to access that information. And so there's a unique identifier that is attached to me as I travel between organizations. That builds out the efficiency, because then if I'm at Hermann and I am making this referral, there are sightlines for me across other organizations that I have intersected with, as long as I, of course, consent to sharing my data through the HIE. There's a whole consent process for that as well. So building the technology required for that leveraging of the MPI, and then building out the connectivity between the healthcare and the social service organizations. And we wanted to do it in a way that closes the loop, right? Which means that when a provider at Memorial Hermann makes the referral to the Houston Food Bank, they are able to see front to back, what is the status of the referral? Has the referral been met or failed? And what does the timeline look like in regards to that particular referral acceptance? This meant we needed to have a valid resource directory for the referral structure. The resource directory means the community organization. What are the community organizations that one can access and refer to? And that needs to be validated, right? Because you can have some resources that might be defunct or non-functional anymore or whatnot. So there was a validation of the resource directory. And then last but not least, this was ubiquitous across all of the partner organizations, was wanting to know, is it answering what we asked you to do? Is it creating efficiency? And is it effective? And so to do that, building out the infrastructure to do that evaluation. And then also, what is the sustainability? You can have a great tool, but is it sustainable? Have people adopted them? What does that sustainability look like? Next slide. So this was our demonstration project schematic for the care network. All this I think we want to preface this by saying this is a network of networks, which means we have leveraged existing technologies that exist in our region that folks have already signed on to and are paying to play to build this out. What this also means is that we can onboard and bring in additional similar models that people are already participating in to create an ecosystem that allows for other care coordination networks and platforms to participate in. So on the left, we have Memorial Hermann Health System. We were intentional in the different types of health systems that were engaged. So Memorial Hermann, which is a large system, Harris Center, that is our mental health authority for the region, Legacy Community Health, a federally qualified health center, and then we have San Jose Clinic, which is community health clinics. What we did on the right-hand side, we have the Houston Food Bank, and the Houston Food Bank really is the community resource hub for the CARE network. What that means, and we've learned a lot about the incredible resource that the food bank is, but what this means is that the Houston Food Bank, thanks to Brian Green and his vision, really is a network that connects to 1,600 plus CBOs in our region. And so we worked with them alongside the Health Connect Texas HIE and their Master Patient Index to really build up and build the capacity for this closed loop referral across 4 health-related social needs domains. So we have food security, financial need, housing, and transportation. Those were our sort of use cases for referral for the CARE network in this demonstration project. Completely able to open that up to more health-related social needs as we scale and grow. But and you'll see in a minute what the CARE network does, but essentially leveraging these existing resources that health systems are already paying to play in Health Connect Texas HIE. The Master Patient Index already exists. It has 27 million patient lives. And the technology, the resource that the Houston Food Bank Hub has in terms of 1,600 plus CBOs, which many of them are networks themselves, allows us to create the seamless care coordination between healthcare and social service realms. So with that, I think the next slide is the video. Am I correct, Heidi? Yes.
You are.
So, okay, so we'll share the video gives a little bit of a snapshot in regards to what happens in the CARE network. We cannot hear anything. Heidi.
Better support the people they serve.
There you go.
Today, we have a real opportunity to help organizations better support the people they serve.
We can hear.
Oh, you can. Okay.
Today, we have a real opportunity to help organizations better support the people they serve by making connections across systems easier and more efficient. Right now, many organizations are coordinating care using one-to-one connections. Without shared infrastructure, providers can miss important information about a patient's care journey. The CARE network is changing that by creating a network of networks, making it easier to refer, track, and manage support for the health-related social needs of patients and clients across many organizations all in one place. With patients' consent, the CARE network connects existing organizational technologies and leverages the Regional Health Information Exchange, linking millions of patient records across our region. Most importantly, community organizations can now connect to hundreds of community organizations under one network umbrella. That means seamless referral experience and shared visibility for healthcare and community partners. Let's see how this works. Meet Rose Kimes, a local Houstonian whose family rushed her to the local hospital emergency room due to complications with her type 2 diabetes. While in the ER, Ms. Kimes screens positive for food insecurity and indicates she needs some financial assistance as she recently lost her job and her health care benefits. The health system's care coordinator speaks with Ms. Kimes and confirms that she would like to be connected to resources. The coordinator uses the CARE network to make referrals for food and financial services. She also refers Ms. Kimes to a nearby clinic for follow-up medical care and ongoing diabetes management.
My name is Melanie McGuire. I'm the Senior Director of Programs here at the Houston Food Bank. Care coordination is really at the center of how we can address needs. Oftentimes when someone's coming in for services, while they may be coming in for an immediate need, underlying, we said that they may have other needs besides that immediate need. Through a team of navigators that can support individuals while they're accessing services, we can identify that that individual may be eligible for other services they may not be even aware of. Co-enrollment in services, as we have learned, is really one of the strongest ways that we can improve quality of life. Oftentimes we hear from our neighbors that there's so many hoops to jump through to be able to get connected to services. And so through the Care Network, we've really established this opportunity to create a seamless connection between healthcare and social care. And that opportunity really is trying to create a better experience for our neighbors so that they can get the critical services that they need through one seamless conversation.
Thank you, Heidi. So with that, Heidi, I'll pass it over to you to talk about what we've learned so far.
Sure. Okay, so to recap our objectives as we looked at this demonstration project of really understanding how did we come together and do this work where we're doing it together. That's unique. It's different than care. A lot of care coordination efforts are one organization or one entity looking to do it within their networks. So first of all, enabling the coordination of care, but across sectors, so across healthcare and social service agencies intentionally. In this case, we're leveraging the health information exchange and the connectivity that Shrila just talked about. And then enhancing the ability to understand what happens with those referrals. Did it work? Did it not? That's one of the key things that we've not been able to tell with the majority of care coordination efforts, not only in our region, but nationally. There's a lot of challenges there with consent and data sharing and HIPAA, et cetera. A lot of that's been navigated, and we've carefully charted this course to allow us to demonstrate the impact of what we're doing through the governance piece. I think the governance kind of in some aspects seems like this big bucket, but really the governance is a roadmap of how do we work together and make decisions together and support our community and the patients and clients and neighbors together. So in that process, we need a level of accountability of if the healthcare organizations do this, then the team on the community-based organization side is going to do this. And in order for the team in the food bank's community services hub to be successful, they need certain things from healthcare. That kind of back and forth workflow is what we mean when we say accountability and good governance. So all of that's been set up, and I will talk a little bit too of how we're like how that works in an everyday aspect. And then the piece that we're looking at currently is the effectiveness, adoption, and sustainability of this model. What does this look like as we move it forward, and what does this mean for our community? So here we're jumping into some of our metrics of success, and credit to Dr. Michaela Sandoval, who's just wrapping up maternity leave, so she's not here with us today. But really what we did is across the organizations participating, we gathered key metrics of success of what did success look like to all the individuals and organizations participating, and pulled that together. And here what you see is a roadmap of the data sources of information. So we've got information from the patients and the clients themselves, from the healthcare organizations, from the health information exchange, which is kind of linking those patient records. There's information that we're learning and gathering through the care coordination platform itself, and also the linkage to the community services hub. So building those flows of data so we can track and understand what's happening. And that's a little bit of what you saw there in the video clip of being able to understand what's happening in an ER setting versus a clinical setting and building those efficiencies into things. So these are some of the metrics that we've been setting up to evaluate in the back end. The minimum data set is a key aspect of how we've been able to establish closed loop referrals across HIPAA and non-protected HIPAA entities. And so that's the minimum data needed to make a referral to the across organizations. So what is that minimal information? Like no information about health conditions themselves is being shared out. But the information that's there has levels of consent, and it's generally self-reported demographics related and interest in services themselves. And then we're also collecting satisfaction surveys and self-reported referral outcomes. Then on the HIE end, we're looking at some of the analytics that Dr. Sandoval and her team do is looking at health outcomes based on the HIE already. And so we're leveraging some of those connection points. Specifically, we'll be looking at ED visits and rehospitalization rates. That will happen with a de-identified data set and kind of build on some of the numbers that we're showing you here today. And then some of our performance indicators that we're tracking are around some of the enrollment, the way that the screening process is happening, the connection across the community-based organizations. And some of this will come from those who are doing the actual care coordination as well as from the patients or neighbors themselves. Okay, so then diving in to what's been happening. So we had we've really had a phased go live with each of the organizations. You can see there, Memorial Hermann was the first to kick it off, launching in mid-October of last fall. San Jose also started last fall, but really the majority of these referrals started in January after the holidays. And you can see the onboarding for Legacy in January and February. They've got a pretty large team, so they've had a couple of onboarding, and then the Harris Center team came on in February as well.
And this is, I think it's mistakenly put 2025. It should be 2026.
Oh, geez, yes, yes, of course, yes. So we'll correct that before we send the slides out. So yes, so that's January and February of this year. And then a key aspect of this work has been bringing together all those who are actually working in the system, sharing what it's looking like from the healthcare coordination side to those who are processing the referrals and doing the triaging of matching clients and neighbors to services, having those rapid review conversations and building out better communication workflows. We've adapted the way the technology works, and we've also adapted the way that we're kind of passing information off based on what we hear back from the patients and those on the ground making the referrals. I would say this is one of the key aspects of when we say workflows and when we say collaborative governance. This is how we work together across organizations. Okay, so where are we at? We've got 19 active care coordinators in the system from the healthcare end, and we've trained a total of 71. So there's a lot of folks who are just kind of new, getting used to the tool at this point in time. We've had 127 unique patients receive services through this with an average of 3 referrals per patient. So this gives us a total of 384 closed loop referrals. We are seeing a success rate at 71% for these referrals. And this is as of March 20th. So last week we've had actually a lot more. We've had a good week of number of referrals coming through. But as of March 20th, we had 37 referrals in progress. So they're being triaged and connecting the patients or neighbors to the services at that point in time. And then we have 19% failed. So I think it's important to double click on what is the failed, the failed rates and reasons. The main reason there is we don't have good contact information. And so we've done a fair amount of collaboration across those participating of what are the mechanisms for double checking, rechecking, and adding other options for contact information. And then there is another category of failed of where the patient doesn't actually want the services. So they're not ready for the services. And so that is also a key aspect of this as we look to build out more efficiencies, really understanding what it is that patients and neighbors are looking for and tailoring it to those needs versus what's coming out just from the healthcare end of, okay, they're screened, they have this need, let's match them to this service. There needs to be that connection of conversation or patient voice of what they're interested in. And then we just had one referral that was canceled. And then we wanted to break it down into the 4 types of referrals that we're doing. So you can see that not surprisingly, the highest number and percentage of referrals is for food services. So not quite 50% of the referrals, 47%, are for food services. And this is for direct food as well as for enrollment in food benefits programs. And then the next highest number, so almost 30% of the referrals are for financial assistance. I'm not sure that that's what we expected, but that's definitely where we're seeing the highest level of request. And I think when you think about food insecurity and the root cause of financial need being under food insecurity, that does make a lot of sense. This is followed by housing at 13% of the referrals and transportation needs at 11% of the referrals. And you can see the variance there of the success rates. And we've kind of already covered what in progress and the failed means, but I do think it's important to look at, what we compared with what Shrila was saying in our region of we are generally seeing on average less than a 50% connection rate and completion rate of referrals. So these are really promising initial numbers. We can just barely say that we've been 6 months in operations, but really for the most part, the overall operations kicked off in earnest in January. So this is closing out on the 3rd month of more of all the organizations making referrals. And then looking at some of our lessons learned, we wanted to share with you kind of, okay, these are the themes that are coming up thus far. And I think the lessons learned are really important as we look at sustainability. And so double clicking on the collaboration, once again, we use this word a lot, but it actually has to happen in order for this work to be successful, in order for us to meet the needs in the community. The collaboration has to lead. We as organizations need to work in different ways in order to not be creating those gaps that patients and community members are falling into across organizations. And that takes governance, that takes conversations of how am I going to work together with your team and you're working together. And that governance has to drive how the technology works. So that's our collaborative framework of what we've built together and having that ongoing communication and linking it then back to input and feedback from the patients themselves. And this is a cultural shift. It is shifting the process to be more impactful. It's looking at, does it work? Shifting from, does it work for me, my organization, my priorities, our strategic plan, to does it work for our community? Does it work for the way that we all work together? Does this work for our patients and clients and neighbors? That community sense is a big culture shift and has been a lot of the work that we've been building. When we talk about capacity building, which is the next item there, this is strengthening that ability to work together in a different way. That's the end-to-end workflow of the work that I start over here in screening and referring in an ER setting or a clinical setting. How do we make that communication seamless? And we've got the tools lined, but it's a different way of working than one individual owning the whole process. That requires ongoing training and also support as we move through the process. It also requires the connections, that technical interface. And so one of the key differences is the technology that we're using is not just a platform on its own. It's embedded integrated into existing technologies. And so one of the key efficiencies for example, the food banks end is the food bank's team of care navigators. They are using their existing technology, and that links back through to the care network and has the closed loop referral, rather than forcing them to go into another technology to add the updates to the work that they're doing. So that's kind of the interface and interoperability that we've built out. One of the key aspects as we look to scale is looking at what is the readiness of organizations to do that. There's a lot of capacity building. There's a lot of understanding of what are the technical requirements, what are the technical contracts that the organizations have already. Because some of that interoperability relies on the way that organizations have already structured their technical contracts and their technical vendors. And then coming to consent. So we've built on existing patient consent processes with the healthcare organization, the consent processes that have been built out into the HIE. As we build more and as we build into additional use cases, we really need to think about how do we maintain those consent processes over time? So it's the consent for data sharing, but also it's making sure that these are services that the patients are interested in. And that is double checking of, okay, are you interested in this referral, and gathering another layer of consent and understanding as well, what is the data needed for those consent processes, and where are those data going, who gets to see them, and what happens over time, particularly as we have shifts across our country. We're seeing an increase of questions around where is the data going, and so needing to be very transparent about the processes of what makes this happen, and also that the data should not, or consent should not be a barrier to services. So if people don't want to go through a tech tool to get the services, what are options of connecting them to the services that don't go actually through this technology system? Sheila, I want to pause there to see if there's anything you wanted to add on the lessons learned.
No, thank you.
Okay. Yeah. Okay, so where are we focused now? On what we shared with you here at this point is a lot of our process evaluation, the initial process evaluation. And as we build kind of these first few months of concrete data and numbers, then we'll be looking at the outcomes evaluation, and how do we connect this through to some of the health outcomes that we've identified as priority metrics of success, and using those in the business model. So this spring, we've really been focusing on what is the participation agreement. So beyond the demonstration project, the governing body, that charter's been built out. And this has, again, been a very collaborative process across all the organizations participating. And then the training materials, those have all been developed for the users of the system, and also maintaining those over time as we add new functionality and features. And then obviously the key part of this business model is building out the sustainability and the business processes. So it will have more announcements on the actual business processes slated for June of this year. And then working with Melanie and the team at the food bank of really enhancing some of those patient-facing communications. So in this age of, technology, smartphones, et cetera, we're looking at enhancing some of the phone call rates with text message communication. So those are some of the new enhancements that are being developed in the system. And continuing on with as we look to the next phases of this, looking at some of the other organizations, we've had a number of organizations come forward who are interested in joining, as well as the organizations that we're already working with wanting to scale to additional teams. So I think across the healthcare organizations, we're seeing them, okay, this is working with this team, now we want this team to start using it as well. So we're doing that scaling within the existing organizations and then looking at the processes for bringing on some of the new interested organizations as the business model comes online. And then what we've shared with you too is the basic model, I guess, for closed loop referrals. So we intentionally did not focus on any specific population or any specific condition in the demonstration project. We've seen, though, as we look to demonstrate impact and opportunities emerging specifically to double click and enhance services, specifically around maternal health care coordination, and then also some opportunities around legal aid support. So when we look at a lot of these health-related services, there's a legal aspect for many community members that's associated with accessing these services. And so we're looking to demonstrate impact through those two service lines, so to speak, as we move forward. There'll be a lot of learning, but that's a part of the process that we'll be looking at doing together, because these are areas where we know patients and community members are falling through the cracks between organizations. And then I think to kind of bring it all together, the key piece is we built this. We built this with collective impact. We built this together for our community as a community resource. It's intentionally a network of networks with capacity to link to other networks and efforts across our community. How can we drive better health together? What does that look like for the other care coordination efforts in our region? How can we be stronger together? Those are the questions that we're asking and that we'd love to have conversations with you all of. This is a resource for all of us. And I think that brings us kind of to the end. We can open it up for Q&A. We've got just a few minutes. A quick shout out of contact us, our new email address for the coalition's new name, the new website, and our social media accounts. They're the same accounts that we had before. So if you were already connected with us, they just have a new name. If you're not connected with us, please do look us up on LinkedIn and Instagram. And then a special shout out of gratitude to our funders who have made this work possible. Comments, questions, additions? I know there's been a lot in the chat. Maybe I'll stop sharing my screen and we can open it up for questions and comments from the audience.
Real quick, there was one in the chat right as you were wrapping up.
Yeah. Oh, Wes, you put yourself on mute accidentally, so we didn't hear the question.
Sorry. Does the EHR referring organization provider need to leave their org's EHR system to make or create the referral in a separate platform? And if not, when the referral becomes completed or failed, does it automatically update the referral status back to the EHR or provide notification to the referring provider in clinic?
So the way individual organizations connect on the healthcare end into the care network is based on kind of how they've structured their own technology. and how they are also integrated with the health information exchange. So we built in some places a single sign-on. There's different ways, and that's a part of the technology assessment, is determining what is the best way for organizations to connect in, and how have they structured their contracts with their EHR vendors. We have found people who've wanted to have it more integrated into their EHR have challenges with their EHR vendors and how to do that. I feel like I forgot the second half of that question, Wes.
And then the latter part, then, so if not,
Yeah.
when the referral becomes completed or failed, does it automatically update the referral status to the EHR or notify the clinic, yeah, or other party?
Yes, yes. And so this is another area where it depends on how the healthcare organizations are already leveraging the HIE. But what we have built out is for the statuses to go through, the tech term is a CCDA record, and update within the EHR's integrate, or the HIE, the Health Connect Texas, the way that they're showing up in that EHR. So again, it depends on how organizations are already using that technology, but we have built out the closed loop referral so that the status of what's happening goes through to the patient's records. And I also think that that's one of the things as we look at next level consent. Right now, it's just the minimum information, but there's opportunities, but that needs to go with consent of what do people actually want on their record. And that takes a fair amount of conversation, because not a lot of patients know what an HIE is and what it's doing with their healthcare records. I think that as a community, we have an opportunity to better serve our community by linking healthcare information. That's just my take on it.
Yeah, I think the interesting part is that there's no incentive for the EHRs to actually talk to each other, even if it's the same EHR. I think the next question, what are the next steps for scaling this work to other organizations? So the short answer to that is yes. We are able to, as you saw from the data, successfully do the screening and the referral and close the loop. So we are happy to, when we send this deck out, and the contact information is there and you can contact us. I will say that there is a certain level of readiness from the healthcare organizations that are interested in participating, IT readiness largely, that would be needed to successfully participate. But all of those things can be figured out. As I mentioned, one of the things we worked on is all of those pieces that are needed from an IT side and legal side and data sharing side. So all of those pieces are in place for organizations to join. What have been some of the most common reasons for referrals to fail? And I'm sure Melanie McGuire can answer a lot more in detail, but or maybe she has already.
No, Melanie, do you want to chime in?
Yeah.
And just shout out to Melanie and her team and everything that they're doing. Huge, phenomenal job.
Yeah, absolutely. I think one, I just want to say for the social care side, for organizations that want to join, if they are connected through the Houston Food Bank, then in many ways they have joined this work. So that resource directory that we referenced earlier is the portfolio of 1,600 organizations. And if they're not connected with the food bank and are on the social care side, then we would be very happy to have a conversation about how to do that intentionally so they can be part of this project as well. We don't need to, we've really built this out so that the integration is really seamless, and that we don't have to have too much technology built out by the social care systems, because these things do get pricey. But I'd say the referral failure, a lot of it, as Heidi mentioned earlier, is around the completeness of records. And when we think about this population, oftentimes that is in crisis, right? There's a lot of volatility in their lives. And so that means that they may, have their phone cut off, or they may have moved. And so what's wonderful about this platform specifically is through those kind of conversations between healthcare providers and the food bank, we've also, developed this cadence of notes that was like, we understand that healthcare providers sometimes will receive nuggets of information that can be really instrumental in being able to connect to people to services more seamlessly. It could be like, actually, my phone's turned off, but the person you should be actually reaching out to is this person. And that's valuable information to us that oftentimes we don't receive. And so that has really been instrumental in helping us be so successful in that 71%. But yeah, I would say most of the time it's incomplete information, meaning that we just can't reach somebody, and we do 3 attempts. So we are very intentional about not closing referrals prematurely because we understand that. And then the other thing, as Heidi mentioned, is readiness, is really honoring where people are in their process. Oftentimes there's a screening and there's an immediate trigger to they must need services today. And sometimes folks are not in a position where they're seeking to do that. So one of the things we've built out in the future iteration is really being very specific about those reason codes so that it provides us greater insight around, maybe someone does need services, or maybe they just want information today. And we don't want to call that a failure. We want to make sure that that's an opportunity to highlight how people are seeking services and through this coordinated platform. So I would say those are really the ones that come to mind.
And last thing I'll say, we are over time, but Maria absolutely would love to, we would love to sit down and talk with you more about as we think about these next steps. Yeah.
And I feel like we need more time to chat, but we'll have to figure that out. If you're interested, please do reach out because there's a lot that's gone into this. I see the question on completion and what does that mean? And these are not check boxes. These are people's lives. And Melanie has done she's very eloquent in this space of what does it mean to complete a service, and we've actually built out a bucket of 3 different categories there of enrolled, received the services, and received education on options for people who wanted the education but they don't want to actually sign up yet. So there's a lot more to unpack here. If you're interested, please do reach out and we're happy to have those conversations. And if it feels like we need to have a more discussion-based follow-up to this, we're happy to find time to do that. Thank you all for being here.
Yes, we'll
Yes,
send the
thank you.
recording out with the past sessions as well in the follow-up email.